Dear friends, in this presentation, we will continue our previous presentation on surgical management of carcinoma stomach as a part 2 presentation. In the part 1, we discussed the broad outlines employed in choosing the surgical management of carcinoma stomach. In this presentation, we will discuss what type of reconstruction we are going to do after a gastrectomy. As you all know, there are three different types of gastrectomy: total, proximal and a distal gastrectomy, depending on the site and size of the tumor. Now, how to reconstruct the digestive tract after doing the gastrectomy? There are several ways of reconstructing it, and there have been several trials analyzing which one is the better suited for immediate and long term outcomes. So coming on to what we had discussed earlier, for a proximal gastric cancer, if it is an advanced tumor, we need to do a total gastrectomy. If it is a small and early tumor, we have to plan a proximal gastrectomy. For a distal gastric cancer, we saw that distal gastrectomy is the ideal treatment. Now, how are we going to reconstruct the digestive tract? We will see this topic in three subheads. One will be reconstruction following a total gastrectomy, the other will be following a proximal and a distal gastrectomy. So there are broadly three different ways of reconstructing following a total gastrectomy. As you can see, the first one is the classical Roux-en-Y esophagojejunostomy, where you take a Roux loop of jejunum 15 to 20 centimeter from the DJ flexor, and then that is anastomosed to the end of the esophagus, and you do a side to side jejunostomy up to 40 to 45 centimeter distal to the esophagojejunal anastomosis. Then there is another way of reconstructing, what will be a jejunal interposition, where you take a jejunal loop, proximally you anastomose it to the esophagus and distally to the duodenal stump. So this is called a jejunal interposition. Another way of reconstruction is what is called a jejunal pouch, where the Roux-en-Y jejunal loop is constructed into a 10 to 15 centimeter sized pouch. This has its own advantages, which we will discuss subsequently. And there is a new form of reconstruction also, where even in the loop of jejunum that is used as an interposition loop, a pouch formation can be done. And if you refer online, you will see different varieties of pouches like S pouch, omega pouch, and the pouches can be an oral or an aboral pouch. So there are several ways of constructing pouches, which serious readers are requested to refer further on different ways of pouches. So coming on to why we should do a jejunal interposition. Why we should do a jejunal interposition following a total gastrectomy. First thing is, by interposing a loop of jejunum, it preserves the duodenal food passage. The passage of food goes from the esophagus into the jejunal loop, and then it goes across the duodenum. Whereas if you do a Roux loop esophagojejunal anastomosis, the food passage bypasses the C loop of duodenum. So this is important, because by the passage of food through the duodenum, it stimulates the secretion of the bile and the pancreatic juice, and the mixing of the chyme with these juices occurs. Also, the gastrointestinal hormones, the upper gastrointestinal hormones, the most important site of secretion will be in the duodenum and proximal jejunum. The secretion occurs only by the food passage across the duodenum, and when there is a good secretion of these hormones, and when these hormones are well regulated, then there is a long-term advantage in terms of weight gain and in terms of overall gastrointestinal health. So by this, by the secretion of hormones and the preservation of the natural duodenal food passage, the digestion and absorption of nutrients is much better compared to a Roux loop esophagojejunal reconstruction. Overall, this results in a very good weight gain, and it improves the long-term quality of life. Now we have several trials which compare the Roneway esophagojejunostomy and jejunal interposition. We had a meta-analysis that was published in 2015. It is a meta-analysis of almost 10 randomized trials comparing a jejunal interposition which had around 350 patients versus a Roux-en-Y reconstruction which had around 405 patients. So it found that when you have a jejunal interposition, the risk of dumping syndrome is very less. There is a higher nutrition index overall, and there is less post-operative weight loss. So this is an evidence of all the factors that I had discussed before, that preserving the duodenal food passage helps in long-term functional outcomes which are going to be better. Also, it does not increase the complexity of the operation or any morbidity attendant to it. So, in a way, this meta-analysis proves that the jejunal interposition is much better in both short-term and long-term outcomes. Uh, Again, we had another meta-analysis under systematic review comparing Roux-en-Y esophagojejunostomy with and without pouch and jejunal interposition with and without pouch. This also, so this basically included the patients who underwent pouch as well. So, is there any impact of pouch in the reconstruction following a total gastrectomy? To start with, there were no differences in the operative time, post-operative complications, or mortality. So, the immediate or short-term outcome is comparable. Pouch patients had significantly less dumping, less heartburn, and a better meal intake. And the quality of life was significantly better in pouch patients, and it increased over time. But at the end of 2 years, pouch patients had better quality of life. So this particular paper, this particular meta-analysis argues for a construction of pouch along with a jejunal interposition limb. So the following a total gastrectomy, jejunal interposition plus or minus pouch is found to have a long-term and short-term good outcomes compared to a esophagojejunostomy anastomosis following a Roux-en-Y esophagojejunostomy. Coming on to reconstruction following a proximal subtotal gastrectomy. So, as we have seen in our previous presentation, following a proximal subtotal gastrectomy, preserving the distal stomach is serving as a function preserving gastrectomy along with good long-term outcomes in terms of quality of life. There is a disadvantage that the acid secreted in the distal stomach can reflux into the esophagus and cause higher incidence of reflux esophagitis because the lower esophageal sphincter function is abrogated due to a proximal gastrectomy. So, this disadvantage is basically overcome by interposing a loop of jejunum, whereby the advantage of retaining the distal stomach is also maintained. So, the reconstruction follows as such by keeping a loop of jejunum between the esophagus and the distal stomach. So, this is called a jejunal interposition. So, why the retention of distal stomach becomes essential? So, it preserves the duodenal food pathway as we have seen in the previous slide. So, it promotes gastrin secretion that happens from the distal stomach. This is helpful in chyme digestion. Then the remaining stomach also acts as a reservoir for food. So, there is a food storage happening. This helps in mixing of the digestive juices, the gastric juices with the chyme. So all these things will result in better post-operative weight gain. In patients who need a chemotherapy after a gastrectomy, this can improve the post-operative tolerance of chemotherapy. The other thing that happens is there is better B12 and iron absorption because the acidic environment of the stomach facilitates the breakdown of vitamin B12 that is bound to the food. So you all know about the physiology of intrinsic factor which is released from the parietal cells in the stomach. It binds to the vitamin B12 in the duodenum. This B12 intrinsic factor factor complex subsequently helps in absorption of vitamin B12 in the terminal ileum. So you have a better iron absorption, you have a better B12 absorption. This ultimately results in better hematopoietic indices. There is a lesser requirement of B1, B12 and iron supplementation following this type of gastrectomy. Otherwise, in any patient who undergoes a total gastrectomy, periodic iron and vitamin B12 supplementation is recommended. So the reconstruction patterns that can be done following a proximal subtotal gastrectomy, one will be doing a esophagogastric anastomosis between the distal stomach and the esophagus. This is the traditional one. Then the second one will be placing a jejunal loop between the esophagus and the stomach. This is called a jejunal interposition. And the third and very recently described is what is called the double tract reconstruction. In this type of reconstruction, a rule loop of jejunum is taken to the esophagus and the esophagojejunal anastomosis is performed. Now, the distal remnant stomach is also anastomosed to the same rule limb around 20 to 25 centimeter distal to the esophagojejunal anastomosis. This is done as a side-to-side fashion. And distal to that, in the same jejunal limb, the regular jejunojejunal anastomosis is performed. So basically, the food can pass through two tracts. That is the reason why it is called a double tract reconstruction. The food passing across the esophagojejunal anastomosis can go to the jejunum and then into the stomach across the jejunogastric anastomosis, and it also can travel downstream along the jejunum. So these are the two tracks the food can travel. So that is the reason it is called a double tract reconstruction. So there was a meta-analysis that was published very recently comparing a double tract reconstruction with a jejunal interposition against a Roux-en-Y type of reconstruction following a total gastrectomy. So basically it compared a Roux-en-Y versus a double tract reconstruction. It was a meta-analysis of 7 studies. Most of the studies happened in countries where there was a high incidence of early gastric cancer. In other words, screening endoscopy is done extensively and gastric cancer is diagnosed at an early stage in Japan and Korea, where they have to do a total or a subtotal gastrectomy for a early gastric cancer. So they compared the double tract reconstruction versus a Roux-en-Y, and they found there is no, and this particular meta-analysis found there is no significant difference in the short-term outcome in terms of operating time, hospital stay. A jejunal interposition with a double tract reconstruction performed as well as a Roux-en-Y reconstruction following a total gastrectomy. And coming on to long-term outcomes like reflux esophagitis and an anastomotic stenosis, which can occur following a chronic reflux of the contents into the esophagus. So there was also no difference in reflux esophagitis and anastomotic stenosis. And in the double tract group, the vitamin B12 supplementation rate is lower. So because there is the distal stomach is retained, the vitamin B12 intrinsic factor pathway is intact, and hence it resulted in the reduced vitamin B12 supplementation rate. So basically this meta-analysis showed us that the double tract reconstruction is as good as a Roux-en-Y reconstruction following a total gastrectomy, and there is a long-term nutritional outcomes are better. So very recently this type of reconstruction is becoming a preferable option following a proximal gastrectomy for a early gastric cancer. Remember, if you have a proximal gastric cancer, which is a large tumor, which is an advanced tumor, total gastrectomy is the option. There are countries where they diagnose the proximal gastric cancers in a early stage, like in Japan and Korea, due to extensive performance of screening endoscopy. In these cases, you can do a proximal gastrectomy for a small early gastric cancer in the proximal stomach and preserve the distal stomach. This is for a function preserving aspect of the surgery, and you can still achieve a better oncological outcome because this particular meta-analysis showed the oncological outcomes are similar in terms of lymph node retrieval rate and the long-term recurrence rate. So in a early gastric cancer, proximal gastrectomy with a jejunal interposition and a double tract reconstruction is emerging as a preferable option. Coming on to reconstruction strategies following a distal gastrectomy. So, a distal gastrectomy can be reconstructed using a Billroth 1 reconstruction where a gastroduodenal anastomosis is done, or a Billroth 2 reconstruction where a gastrojejunal anastomosis is done. Sometimes you can do a Roux-en-Y gastrojejunostomy where you take a roux loop and anastomose the roux limb to the remnant stomach. There is a new technique described, what is called an uncut Roneway, which we will see subsequently. So these are the various ways of reconstruction following a distal gastrectomy. If you refer the textbooks, you see there are several names of reconstruction like Polya, Henke, Mikulicz, and several others. So these are all different types of reconstruction following a Billroth 1 and Billroth 2. And finally, you have a Roux-en-Y gastrojejunostomy. So, what are the advantages and disadvantages of each type of reconstruction? A Billroth 1 reconstruction where a gastroduodenal anastomosis is performed is physiological because it retains the duodenal food passage and thereby normal upper abdominal digestion and absorption. However, because there can be anastomotic tension, you have to mobilize the duodenum for doing the anastomosis. There can be anastomotic tension and its related anastomosis related complications. In Billroth 2 reconstruction, where a jejunum is taken up for a gastrojejunal anastomosis, this anastomotic tension is very less. So, anastomosis related complications are less. However, the remnant stomach is exposed to biliopancreatic secretions. So this can result in remnant gastritis, and again there can be reflux esophagitis as well. Then the so-called dumping syndrome, where there can be rapid gastric emptying due to the anastomosis into the jejunum. The gastric food contents directly enter the jejunum without going through the C loop of duodenum. This can result in the dumping syndrome. Then the duodenal and biliary pancreatic juice, which can reflux into the stomach, when it is going to reflux for a long period of time, this can be a potential risk factor for malignancy. So, what is called the gastric stump carcinoma can occur in long-term survivors following a Billroth 2 reconstruction. So what happens in a Roux-en-Y gastrojejunostomy? It is a bit of technically demanding because the number of anastomosis is more. You have to take a roux limb and then anastomose it to the distal stomach, and there is a jejunal anastomosis. Then the limb that is anastomosed to the stomach, that is called the roux limb. So this roux limb can have a bit of motor incoordination resulting in a slower peristalsis. So this is called a roux stasis syndrome. The roux limb, the rate of peristalsis in the roux limb can be sluggish, or it can be an aperistaltic limb. So this is called roux stasis syndrome. So this can result in delayed gastric emptying. And the third one is if we have to access the bile duct for a future ERCP in these patients, having a Roux-en-Y anatomy, this is going to be difficult. So these are all the disadvantages with a Roux-en-Y gastrojejunostomy. Now we will discuss the studies that compared a Billroth 2 reconstruction versus a Roux-en-Y gastrojejunostomy. We had a meta-analysis of 4 randomized studies and 8 retrospective studies totaling up to more than 1,300 patients. So they found that with Billroth 2, the operating time is lesser, There is no difference in postoperative complication between the two types of reconstruction, no difference in delayed gastric emptying. They found there is more reflux in Billroth 2 reconstruction, and there is less incidence of dumping in a Roux-en-Y reconstruction. So basically, this study tells us that the long-term outcomes are better with a Roux-en-Y type of reconstruction following a distal gastrectomy. Now coming on to what is an uncut Roux-en-Y reconstruction. This is a very recently introduced type of reconstruction. When we do a Roux-en-Y, we need to divide the jejunum 10 to 20 centimeter distal to the duodenal flexure, and the jejunal limb is taken for the anastomosis either to the esophagus or to the stomach. Now, when we divide the jejunum, this also interrupts the myoelectrical continuity of the gut. So, this can result in a change in the direction of muscle contraction, and that can impair the normal intestinal peristalsis. So, this can result in an aperistaltic Roux limb and thereby a delayed gastric emptying kind of picture, what is called a Roux stasis syndrome. So the Roux limb is the limb that is between the esophagojejunal or gastrojejunal anastomosis and the distal jejunojejunal anastomosis. So this limb can become aperistaltic, or the peristalsis can be sluggish and can result in delayed gastric emptying type of symptoms. So what happens in uncut Roux-en-Y is there is no mesenteric division. The jejunal limb is taken up without any division, and it is anastomosed to the remnant stomach. Now, how can we still maintain the advantage of no reflux of biliary and pancreatic contents into the stomach? So this is by dividing the afferent limb of the jejunum that is going to the stomach. This division can be done with a stapler. So wherein you, as the picture shows, the afferent limb is divided, and distal side to side jejunal anastomosis is constructed. So the biliopancreatic secretion goes to the distal jejunum across the anastomosis, and the food goes to the jejunum across the gastrojejunal anastomosis. There is no mixing of biliopancreatic secretion into the food contents in the stomach. So this basically is called the uncut Roux-en-Y anastomosis, because there is no bowel division or there is no mesenteric division. This can preserve the jejunal continuity, thereby the integrity of myoelectrical conduction, and the direction of gastrointestinal muscle contraction is preserved, resulting in normal intestinal peristalsis. This is one of the ways that can be employed to counter what is called a Roux stasis syndrome. Now again, we had several studies comparing different ways of reconstructing after a distal gastrectomy. We had a meta-analysis of 8 randomized studies comparing Billroth 1 versus Billroth 2 and a Roux-en-Y type of gastrojejunostomy following a distal gastrectomy. In this particular meta-analysis, around 1100 patients were studied, and they found that with Billroth 1 there is less operative time and less delayed gastric emptying, which is understandable because there is a single anastomosis that happens between the stomach and the duodenum, and there is no impairment of myoelectrical conductivity, so there is less gastric emptying. However, Roux-en-Y type of reconstruction had less bile reflux and less remnant gastritis, so the long-term outcomes are better with a Roux-en-Y type of reconstruction. Now, we had a meta-analysis comparing a Roux-en-Y type of reconstruction with an uncut Roux-en-Y type of reconstruction. This meta-analysis included 2 randomized studies and 4 retrospective studies. In this, the uncut Roux-en-Y type of reconstruction had less operating time and less blood loss, because there is no division of mesentery, and the suturing of mesenteric rent is not involved in this particular type. And again, it has been proven in this study that an uncut Roux-en-Y has less incidence of delayed gastric emptying and Roux-Stasis syndrome and reflux gastritis. So thereby, in this meta-analysis proved that an uncut Roux-en-Y type of reconstruction has a very good long-term outcome after a distal gastrectomy. So, dear friends, to conclude, the types of reconstruction following a total gastrectomy, a jejunal interposition is a preferable type of reconstruction compared to a Roux-en-Y. Following a proximal gastrectomy, jejunal interposition with a double tract reconstruction is emerging as a good option. Following a distal gastrectomy, a Roux-en-Y reconstruction is preferable for potential long-term survivors because the long-term outcomes are good. We can think about constructing a uncut Roux-en-Y type of reconstruction as well in these patients. Thank you, dear friends. Hope you find this useful. Kindly subscribe to our YouTube channel. Thank you very much.